Good morning, everyone. I'm glad to be part of the ASWARS today. Thank you to the board. And thank you to Dr. Alaa Ghis for the very perfect start to the continuation of systemic disease and how it affects the ocular surface. So the ocular surface is not only collateral damage in the cases of systemic autoimmunity, but actually it is the front line of systemic autoimmunity, and it ranges the progression from a simple dry eye to more severe dry eye to actual epithelial breakdown, ulcers, and scleral necrosis, etc. And we're going to show you a number of cases about how rheumatoid arthritis can affect the ocular surface. So this is a 52-year-old female patient with rheumatoid arthritis or known rheumatoid arthritis, and she has foreign body sensation, fluctuating vision, and she's been suffering in silence, as you can see in her photo, that she has filamentary keratitis, and usually the redness is minimal and disproportionate from the symptoms or from the complaints of the patient. So when we examine these patients, we see that their tear meniscus is structured in these patients, and it's very important to emphasize that yes, we're going to give drops, yes, we're going to give some topical steroids, but it's very important to control the condition systemically. So the next patient is a 42-year-old female patient with a persistent corneal ulcer. I had a number of photos pre-treatment for this patient, but unfortunately they're all lost. Am I very sad and angry? Yes, but this is how things go sometimes. And she was coming on antiviral and antibiotics chronically, and she was on impending perforation, شعرة had perforate, and she was referred to me for maybe this is something autoimmune in the ocular surface or whatever. With a very simple question about her history, the patient told me, yes, I have rheumatoid arthritis, but I'm not on treatment. And this was the key to what she's on. She was only on hydroquine, which we know it does not have a systemic effect on the autoimmune process necessarily. And she was hypothyroid. From going to an impending perforation to 3 months later, of course, the topical antivirals and antibiotics were completely stopped. And I kept her actually, like Dr. Shafiq said, on intense topical steroids and with prepared serum, first from her autologous serum, and then we were able to find her a topical cyclosporin with immunomodulatory therapy. Started first on methotrexate. Unfortunately, she developed some sort of interstitial lung fibrosis, so she was switched to Actemra, an anti-interleukin-6, which is tocilizumab, essentially. And it was completely healed, just this very minor area of opacity paracentrally. Due to financial reasons, she couldn't continue on Actemra, and she lost follow-up. She disappeared. She was kept on adalimumab by the rheumatologist, and 6 months later, she presented to me again in the other eye with, as you can see, a peripheral ulcerative keratitis that showed a peripheral crescentic thinning and an epithelial defect. We returned her back. We recommended to her rheumatologist to put her back on Actemra, and then she had the complete healing, as you can see 2 months later in her photo. The third patient is a patient with somewhere in the ocular surface where we usually do not consider it, so it's only pure, not only pure cornea or conjunctiva, but we have to consider that also the sclera itself is part of the ocular surface. So this was a 32-year-old male patient with rheumatoid arthritis complaining of pain that is severe, waking him up, and this is very important because the hallmark of scleritis is pain. They usually wake up with pain at the beginning of dawn, and then it gets worse as they in the early morning. So the sign was very clear that she had necrotizing scleritis, as you can see at 4 o'clock, and there was also some sort of peripheral keratitis that's associated, but there was a drop of vision in the left eye, and this is why we should examine these patients in the posterior segment and take vision in all cases, because this patient, as you can see, the very characteristic T signs, he also had a posterior scleritis. Very aggressive systemic corticosteroids to begin with methotrexate adjustment. He failed it, so we had to put him on adalimumab, again failed, and we had to put him on Remicade as the last resort. The fourth case is a 56-year-old male patient coming with recurrent necrotizing scleritis over the years. He had no underlying systemic disease initially, but on his investigations, we found that he's rheumatoid arthritis, and of course, the very important aspect is having a multidisciplinary approach with a rheumatologist that you trust and that you know that they're going to be thinking on the same level or thinking about the same kinds of management and their importance. So just emphasizing with patients of necrotizing scleritis, it's important to image them, like take very good pictures in all directions so that when they develop a new nodule of activity, you can catch it. This is our patient when he was inactive and he had an active nodule, and as long as he's active, this means that his systemic treatment is not effective enough, so we need to push his treatment, initially on methotrexate. Now he's in adalimumab and he's been controlled for 2 years. I tried, just the past month, I tried to space out the adalimumab. It recurred again, so we keep it at 40 milligrams every 2 weeks. This was one of the more interesting cases. She was referred to me because she had scleromalacia, no history of any surgeries before, no squint surgery and so on. And she had very tiny thinning. That was quite interesting because it's symmetrical in both eyes and on both sides, temporal and nasal. And actually, she turned out to have rheumatoid arthritis, even though it's been said that scleromalacia is not one of the cases that we see very often. This last case is very important because we need to remember that rheumatoid arthritis, at the end of the day, when patients are on treatment, they're quite immunocompromised or immunosuppressed. So if the rheumatoid patient tells you, I'm irritated, this does not necessarily mean he only has dry eye. This was my patient that's 58 years old, and she was a female on treatment for rheumatoid arthritis and was doing very well for a very long time, presented to me in the clinic with irritation in the left eye, decreased corneal sensation, and as you can see, a full-blown picture of a herpetic ulcer or herpetic keratitis. It's very important before staining patients to check the corneal sensation, of course, if we suspect herpetic keratitis. So for the immunocompromised patients, I don't only give topical. As Dr. Ahmed Al-Masri said, I prefer to give also oral, not only for the keratitis aspect, but because I fear that they shift into a keratouveitis. So I start oral along with the topical treatment, and actually at 3 weeks, she was completely healed. So as you can see, this is one big entity and has so many different phases. It can be only affection in the level of the tear film with a dry eye. And the mechanism here is a lacrimal gland autoimmunity. It can be a peripheral ulcerative keratitis, and the mechanism is a bit different with an immune complex vasculitis. And scleritis is also due to systemic vasculitis, and it can be infection, and this is due to the immunocompromisation and the immune dysregulation. So we have to also emphasize that not all inflammation and rheumatoid arthritis would be autoimmune. It can be infection and it has to be excluded before raising immunosuppression. So as we said, just to summarize, that the ocular surface is a continuum of the immune injury, not an isolated entity by itself, because patients sometimes think that the drops are going to solve the problem. You just have to counsel them very well that the systemic treatment is the main basis, and they have to be very compliant to their treatment. The severity of the disease on the surface reflects activity. When the patient comes with filamentary keratitis that's not resolving, we tell them that this is because the systemic treatment is not doing very well. PUK and necrotizing scleritis are, of course, medical emergencies that would require pushing high doses of steroids until we adjust their systemic treatment, and we have to always exclude infection in a patient that's immunocompromised, the very important part of teamwork and a multidisciplinary approach. Thank you for listening.